Hi, welcome to TCTMD. My name is Mamas. I'm the Senior Clinical Editor and I'm at India Live. Today, my guest is Professor Vinay Bahl. You are the ex-head of department at AIIMS in Delhi. So welcome.
Thank you.
So we're going to talk about valvular heart disease in India. Perhaps you can start by telling us around the epidemiology of this condition in India.
See, we talk about this era of TAVI, TAVI or aortic valve replacement percutaneously. But in India, still the problem is rheumatic heart disease. In United States or many developed countries, the rheumatic is not a problem, but we face that is still a number one problem as far as valvular heart disease is concerned. And those patients are younger. So we divide actually the rheumatic heart disease countries into low prevalence and high prevalence countries.
Yes.
So we are amongst the moderate to high prevalence countries. That means that there are 2 per 100,000 patients of rheumatic heart disease and 1 per 1,000. So that is rheumatic fever in 5 to 15 years. And a general population, if you take rheumatic heart disease, it will be if it is more than 1 per 1,000.
Right,
in the statistics or prevalence wise, it varies from 0.5 to 5%. Various cities, they have done surveys. ICMR has done so.
I guess, there's a lot of discussion in India, 3 million cases of rheumatic heart disease. What sort of age do these patients present when they come to attention to you as the cardiologist?
The rheumatic fever, which is which leads to rheumatic heart disease, the involvement of valves, is most prevalent in 5 to 15 years of age. And it takes about 10 years or 5 years before the valves get involved.
Yes.
And the most common valve is the mitral valve. So mitral stenosis is almost an epidemic. And as you know, the percutaneous treatment of rheumatic mitral stenosis, that is PTMC or balloon mitral valve, what we started here. Our first paper was in New England Journal with Jim Locke. He came here and did the first case. And then that, Inouye balloon took over. So, but the other valves take time. So we also have reported cases of quadrivalvular disease, but isolated aortic stenosis in rheumatic is very uncommon, to the tune of only 1%. There can be multivalvular disease. Most common combination is mitral stenosis and mitral regurgitation, followed by mitral and aortic valve disease, which is mainly the aortic regurgitations, but there can be involvement of aortic and even pulmonary valves. So this is how the profile is.
So, there's disparities everywhere, and we've seen them in North America and Europe, but particularly in places like India, they're much more evident. Is there a challenge in identifying valvular heart disease, particularly in rural areas in India?
It's a challenge, but it is improving because till a decade back, all the expenses were out of pocket. Now government is providing in a big way. They are opening the medical colleges. They are opening the AIIMS. So they are providing the government insurance scheme. So the healthcare facilities are growing. So they can be identified patients, very early and they're treated.
I guess there's equality of access by virtue of funding, but of course you also need medical institutes in these areas.
Technology
and techniques. Is that a challenge in India?
It is a challenge. That's why we have a medical system where we train the doctor. We call them super specialists, like it's a DM cardiology. So those courses are increasing in number. So more and more people are being trained. And of course, these type of conferences also makes you, when we could get the foreign experts and we learn from them. So this helps.
I guess when you go to many meetings, the focus is very much on percutaneous treatment of valves. How much growth has there been in India? Have you seen this technology enter India, or is it still lagging behind other parts of the world?
I'm sure you are talking in context of TAVI.
Yes.
But our percutaneous used to be a rheumatic mitral valve stenosis, balloon mitral valvotomy.
Yes.
So if you look at the TAVI, we don't have exact statistics of how many people have aortic stenosis, but as a rough guess, we are 1.2 million. Okay. And there is a statistics that 5% of them are more than 65 years of age. So if you take the epidemiology from the West, so there will be 300,000 patients who have aortic stenosis, which you said are potential candidates for TAVI. But this is just statistical things. If you look at the TAVI numbers, They are now reaching around 3,000 a year.
Okay. That's for the whole of India, 3,000.
Yeah. Just going, but it will go exponentially because now the government has also allowed the TAVI procedure in the government scheme, which I was talking about, the CGHS and the.
And often in environments where perhaps the funding is an issue, that can drive local technology. And I mean, maybe you can talk to us about some of the development of more local valves.
That, as you rightly pointed out, that happens, and government is also encouraging, providing a lot of incentives. We used to have that Medtronic and Edwards valve. Now we have an Indian company which has come in a big way, Merrill. So they have my valve, which is almost about half the cost of the imported valves. And there is also the Hydra valve, basically developed in Thailand, then came here. And there are a lot of companies who are interested in making collaboration with the multinationals to make it indigenously. So the cost is still a factor, but the indigenous development of the valves has helped it.
So I guess from your perspective, I mean, you're a senior clinician, you've practiced for many years. When you see a patient with severe aortic stenosis, I mean, what are the factors from an Indian healthcare perspective that play into whether they get surgical or transcatheter treatment of their aortic stenosis?
One thing we must remember that the surgery is much cheaper in India in the government sector, but not in the private sector, because the infrastructure is provided by the government. You only have to pay for the valve, which is much cheaper than the percutaneous valve. So the statistics we apply in the West doesn't apply to the Indian context. So when we look at, I think the age should be a very, very big criteria. Because I've seen people now doing even younger patients, so 60 years if you do, and we don't know whether this valve will last more than 10 years or no. We have few data on 5 years and one data on 10 years. So that must be the first factor, the age, because obviously rheumatics are excluded in that age group. So it has to be age. Then other comorbidities and the other usual suspects that are relative of underweight. But Indian patients have a unique thing that their body size is less, their annular size is less, the valve size will be less. So how they will behave in the long term, we have to see and follow these patients very closely.
I mean, when it's sort of financially driven, these sorts of discussions, I guess patient choice becomes much more important, the ability to pay or the willingness to undergo a procedure. How much does that have an impact on whether you offer the patient surgical or transcatheter?
It happens, but if you ask me frankly, it is how I put it into him. If I tell him that the surgery also can be done, but yes, it involves this. Or if I say, no, TAVI will be better, but surgery can be done. So he is influenced by how I put the case to him, because most of the Indian patients are not that much well read. They have not Googled the subject thoroughly to come before a doctor. So they mostly leave it to the doctors, but of course, they usually take the opinion.
And I guess one of the things that we can talk about is the limitations of data. I mean, we have great evidence base around TAVI. The problem is that a lot of this evidence base is derived from North American, European populations. I mean, how applicable do you think that data is to India and Indian populations? And is that a challenge for you clinically?
See, basic things is not a challenge, but yes, we have to have our own data to see how it behaves in Indian population because of body size, the annular size. If you put a smaller size walls, how they behave differently. But by and large, we have been following the Western data and Western guidelines. If we sit down and try to there are a lot of Indian guidelines coming in all of the subjects. But without data, it becomes expert opinion rather than, based on the facts. Based on epidemiology.
And I mean, from the national leadership, from the cardiac societies, I mean, do you have ongoing registries in India for?
Yes.
You can expand.
We have, like the Cardiology Society of India, they have a PTCA registry. So they are having it for many years. So basically they used to collect the data of number of cases and number of complications, like broad data. So now they are dwelling into, finer aspects of the data collection. So, but still, lot needs to be done. The data has to be authenticated. Now, at least in coronary era, we are seeing more and more trials coming from India. We have a trial of registry of large registry from IVL. We had a stent data registry in diabetic population, especially. So I'm sure as the number grows, we will also have the TAVI, not only the registry, some randomized trials of comparing the maybe indigenous valve with the valves which are costlier.
I guess my final question to you is, how do you see the treatment of aortic stenosis evolving in India, say in the next 5 to 10 years, particularly given that your population is very different from North American or European?
Yeah, if we talk in the context of aortic valve disease, I think, Indian patients also don't want to undergo surgery. Okay. If they want to avoid surgery as far as possible, that's forgiven. So if they are offered a percutaneous choice, they'll always lap for it. But I think it will grow. It will grow because the cost was a major limitation as far as TAVI is concerned. So now the cost will come down as the volume increases, as the indigenous valve will provide some competition to multinational companies. So more and more this technology will be available. Manpower is increasing. The manpower is being trained thanks to the foreign guest faculty which come to like these meetings. Yes. So they teach a lot. So if you go to any Indian center, there will be proctors coming from all over to teach these new techniques and technology. The best part is that India, now whatever is available in the West is available at least. Yes. So if you can afford, you can have whatever is available outside. Otherwise, Indian patients used to come 2-3 decades back to United States or Europe to get these things done. Now everything is available here.
And do you think, the very final question, I mean, I'm aware of legislation in relation to stents. Do you think that legislation will drive adoption also from the perspective of percutaneous treatment of valves?
This is not because recently, about a month back, the CGHS, which is a government scheme, they have given the permission to implant the TAVIs in the same rate as indigenous valves are available. So if you talk of if the multinationals have to compete, they have to compete on that rate if they have to capture the masses. But otherwise, there are private sectors which people can afford anything, because 1% of India is super rich.
Yes.
No, so they can afford anything. But if for the masses, yes. But I don't think this stent story will be repeated in TAVI.
Okay. So with that, I'd like to thank you, Vinay, and I'd like to thank our viewers on TCT MD, and congratulations for India Live. It's been a real pleasure attending.
Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.